Ribavirin for chronic hepatitis E virus infection in transplant recipients. My name is Daniel Ocampo. Definition: hepatitis B is a serious liver infection caused by the hepatitis B virus. For some people, hepatitis B infection becomes chronic, meaning it lasts more than 6 months. Having a chronic hepatitis increases your risk of developing liver failure, liver cancer, or cirrhosis, and condition that permanently sarks of the liver.
Hepatitis E is RNA virus, spread by the fecal-oral route. Incubation period 3 to 8 weeks. Common in Central and Southeast Asia, North and West Africa, and in Mexico. Causes a similar disease to hepatitis A, but carries a significant mortality, about 20% during pregnancy. In general, hepatitis E is a self-limiting viral infection followed by recovery. Prolonged viremia or fecal shedding are unusual. In acute infection, IgM antibodies to hepatitis E virus are positive. Does not usually cause chronic disease. A vaccine is currently in development, but is not yet in widespread use. Thank you for watching. For more
Applications in medicine. The median time between the diagnosis of HIV infections and the initiation of Ribavirin therapy was at the time that Ribavirin therapy has initiated. 34 patients had presently positive tests for serum HIV RNA. For at least 6 months, 20 patients had viremia for 3 to less than 6 months, and 5 patients have been infected for less than 3 months. Pros and cons. Today there is no establish a therapy for IgV infection, a reduction and immunosuppressive therapy, mainly suppressants that target T cells, has resulted in IgV clearance in nearly 30% of solid organs transplant recipients with chronic hepatitis. 6 to 10 small case series and case reports in this population have shown that a short course of pegylated interferon or ribavirin as monotherapy can be effectively treat HB infection.
Hepatitis E virus, referred to as HEV, is a common cause of sporadic and epidemic acute liver disease in developing countries. In the United States, sporadic cases of both imported and locally acquired HEV infections are mostly seen among adults. Incubation ranges from 15 to 60 days following exposure, with an average of 40 days. Liver enzyme elevation, as shown in blue and labeled ALT for alanine aminotransferase, usually occurs 4 to 5 weeks after exposure to HEV and persists for 3 to 13 weeks. Symptoms noted by the purple bar occur when liver enzymes are elevated. Virus excretion in stool, illustrated by the orange bar, is variable, but usually lasts from about 1 week before symptoms appear until about 1 week after they have surfaced. However, this time frame can be longer in some people. Viremia in acute self-limited infections, shown by the green bar, can be detected about 3 weeks following exposure or a week or so prior to onset of symptoms and lasts for about 2 weeks. Antibodies to HEV, both IgM anti-HEV, depicted by the pink hatched line, and IgG anti-HEV, illustrated by the black hatched line, are usually positive about 3 to 4 weeks after exposure. IgG anti-HEV persists, but IgM anti-HEV declines rapidly during early convalescence and is usually negative by 13 weeks. HEV serologic testing in persons with acute hepatitis, for which other causes have been ruled out, may be performed, especially in someone who has recently traveled to an area where HEV infection is more common. Chronic HEV infection is rare, but has been increasingly recognized in immune-compromised patients. Immunoassays to detect anti-HEV are commercially available, but are not FDA approved. Nucleic acid tests for the detection of HEV RNA are performed in research labs, but are not commercially available. This segment is now complete.
Issue applied in Ecuador. Vaccinate a newborn in the first 24 hours is essential to prevent mother-to-child transmission of hepatitis B. In Ecuador, for example, hepatitis B is a notified disease, and the most important prevention interferon is a universal vaccination, which can be prevention infection in 95% of cases to continue making progress towards elimination the disease. The Ministry of Health has intensified vaccination campaigns and diagnostic teams in the populations. The national plans aim to eliminate mother-to-child transmission of hepatitis B in the next 5 years. Conclusion. In the conclusion, this retrospective multi-center case series show whether that ribavirin as monotherapy may be effective in treating chronic HIV infection. A 3-month course seems to be an appropriate duration for this therapy. Through a longer therapy can be given to heavily immunosuppressed patients and those who still have viremia 1 month after the initiation of therapy, who however prospective studies and recases to determine the most beneficial dose and duration of ribavirin therapy.
Delta hepatitis caused by infection with the hepatitis delta virus, referred to as HDV, is not seen commonly in the United States. Because HDV requires HBV for replication, it can only infect someone at the same time as HBV, called co-infection, or infect someone who has chronic HBV infection, called superinfection. If detected, it is usually in the context of a hepatitis B outbreak, or perhaps when a patient with acute hepatitis B has a more severe clinical course than expected. HDV and HBV co-infection occurs when a person becomes infected with both viruses at the same time. Evidence of acute hepatitis B is depicted by the red hatch line, denoting hepatitis B surface antigen, or HBsAg positivity. The blue hatch line, total anti-HBC positivity, and IgM anti-HBC positivity, shown in yellow. Total antibody to HDV, referred to as anti-HDV, shown by the green bar, is detectable during the course of infection in about 85% of co-infections. Total anti-HDV generally declines to undetectable levels after the infection resolves, as reflected by the rise of antibody to hepatitis B surface antigen, anti-HBs, depicted by the orange hatch line. There is no serologic marker that persists to indicate that the patient was ever infected with HDV. Total anti-HBC and anti-HBs remain positive and denote immunity to future infection with both HBV and HDV. Patients with co-infection develop chronic infection less frequently than those with HBV infection alone, about 2%, compared with from 2 to 6% of adults infected with HBV alone. If HDV infects a person with chronic HBV infection, as depicted by HBsAg in red and total anti-HBc in blue, it is called superinfection, and most persons will remain chronically infected with both viruses and often experience more severe exacerbations of their liver disease. Total anti-HDV, total anti-HBc, and HBsAg persist indefinitely in these patients. Although there are commercially available assays for detection of anti-HDV, and some state laboratories use these for testing, none are FDA approved in the United States. Nucleic acid tests, NATs, for detection of viremia are used in some research laboratories, as well as at CDC, but are not commercially available. This segment is now
Thank you. Immunotherapy in renal cell carcinoma. Definition. Renal cell carcinoma is a third type of urologic cancer has a poor prognosis with 30% of metastatic patient at diagnosis. The antigenous and target immunotherapies led to treatment remodeling in patients to the role of tumor. Microbiome, however, long-term responses are rare with a high rate of resistance. New strategies are emerging to improve the specific and the emerging drugs and organ evaluations in ongoing trials. With the therapy's different treatment options, there is an urgent need to identify biomarkers in order to predict the efficacy of drugs and to better stratify patients.
I think it's a truly exciting time. I mean, bladder cancer has been pretty much neglected for decades. We only had cytotoxic chemotherapy that had some modest efficacy, I would say, in patients, and now we are witnessing a true revolution with the approval of 5 immunotherapies. We're still, I think, working our way through in how to best identify patients who might benefit from these therapies and how to improve these therapies. But I think we are witnessing very durable responses in a subset of patients who can benefit from these therapies for years with really sometimes minimal side effects. I think this is pretty gratifying for any medical oncologist. So kidney cancer has always been kind of like a immune responsive tumor. It's really the only other cancer where we have essentially old-fashioned immunotherapy, high-dose interleukin-2, similar to what we use in melanoma, approved with long-term benefits. So since November 2015, we have nivolumab approved, a PD-1 inhibitor, and we do know that we can induce very durable responses in a small subset of patients, around 21% of patients. However, simply speaking, it's not enough. And I think the future is going to be to look at combination therapies. This will come forward in the short term, I would say, in 2 different flavors. One is the combination with VEGF inhibitors, and the other one in combination with another immune checkpoint inhibitor called CTLA-4 inhibitor, Yervoy. And I think we will witness in a very short amount of time how the first-line therapy for kidney cancer is going to be transformed. It's going to be driven by immunotherapy, truly.
Applications in medicine. Immunotherapy with monoclonal antibodies direct against programming the cells DID1 protein and cytotoxic T lymphocyte antigen 4 has become an integral part of management of renal cell carcinoma. The fields of immunology and oncology have been linked since the late 19th century when the surgeon William Coley reported the injections of killed bacteria into size of sarcoma could lead to tumors shrinkage. Since to times exponential advance in the understanding of interaction between immune suppressor and tumor growth and development have led to broad therapy advances are now being started in all cancer types.
I think the most interesting data and the one that people are very excited about is the Emotion 151 that we just heard from Dr. Bob Motzer. And this is a phase 3 randomized trial that looks at bevacizumab with atezolizumab versus sunitinib in a phase 3 setting for advanced metastatic clear cell or kidney cancer. So let me just give you a little background on how we treat kidney cancers or advanced kidney cancers. So certainly there has been a lot of landscape changes. In the past, if we go back even a decade ago, we really did not have a lot of systemic therapies to offer. But now we have VEGF inhibitors, so these are what we call the TKIs. And certainly we have the immunotherapy drugs, but mostly for second line right now. So with the advent of this trial, the landscape of treatment is really changing. So in this phase 3 trial, though, what they saw was a phenomenal and very compelling improvement in the progression-free survival. The overall survival is yet immature, but we are seeing that there is two co-primary endpoints. One is progression-free survival in patients who are PD-L1 positive, and in this population there was about 40% of them, as well as an intent to treat population. And what they found was the PFS, for instance, for the combined therapy is in the order of 11.2 months, compared to only about 7 months for the sunitinib arm. So these are compelling data. And in terms of toxicity, actually there's not a whole lot that it's unexpected, if you will. So I think it's a fairly tolerable regimen. So I think moving forward, this is a great candidate. Perhaps, we will be seeing more this year. I think it's rapidly evolving. And the trial I just mentioned, the Emotion trial, is but one of them. Last year at ESMO, we heard about the Checkmate 214 trial, which looked at the combination of nivolumab and ipilimumab versus, again, sunitinib, and that was also a positive trial. So we are starting to see now these combination IO drugs that are pretty soon going to be changing the landscape of treatment, because right now IO therapy has largely been second line therapy with nivolumab. So I think we are starting to see these agents move up, and not just maybe single agents, but in combination.
Pros and cons. For patients with treatment-favorable risk days who are asymptomatic or minimal symptomatic with a limited disease burden, we suggest clofazimine surveillance to determine the pace of disease. Surveillance allows the deferral of therapy in the associated toxin until more complete disease progression is documented.
So the things are clearly evolving for several years now, but especially since last ESMO, where we had the results of nivolumab versus everolimus randomized phase 3 study, which demonstrated that in patients who failed one or two VEGF-added therapy, there is a role for IO immuno-oncology, and namely nivolumab. It is important because this is changing one of our standard of care, and since last year this has been implemented in all of the guidelines. What is important at this ESMO is that we're starting to have more information on which will be the next step in terms of combining those agents, for instance.
Each applicating Ecuador, the choice of treatment for patients with advanced disease has been based on prognostic risk factors historically developed in the era of frontline vascular endothelial growth factor risk. Tyrosine kinase inhibitor, the International Metastatic Renal Cell Cancer Consortium, prognostic the model integrates adverse factors.
Checkpoint inhibition, that is actually a form of immunotherapy. So that whole class of therapy, what it essentially does is ramps up your own immune system and releases the brakes that the tumor created to slow down your immune system from fighting your own cancer. It lets go of the brakes so that you can fight the cancer yourself. And when it works, it is actually astounding. It's really quite remarkable. It doesn't work for everybody, but when it works, it's really quite remarkable. Well, interestingly, checkpoint inhibition, again, this immunotherapy approach, that has exploded on the scene for bladder cancer as well. And that is rapidly changing the paradigm for the management of advanced bladder cancer. And so there's active trials ongoing right now trying to figure out exactly what space that therapy should fit in. Should it just be in metastatic disease, or does it have a role in locally advanced disease, or even earlier stages? So that is probably the single biggest advance in the last couple of years, and it's just taking bladder cancer by storm.
Conclusion: for most patients with advanced clear cell renal cell carcinoma, systemic therapy is a typical initiation promptly when under-rest disease, age-term metastasis, or locally advanced. Is present the decision to start systemic therapy, and the selection of agent depend on disease, relative symptoms, patient comorbidities, and tumor risk stratifications.
The combination in immunotherapy are focused on the first line, and clearly it's the future. It's already the standard treatment with double IO or IO-TKI. But the main point, we have two challenges. First, we have to know how to select the good combination for the good treatment, for the good patient. And we have IO-IO or IO-TKI, and we don't really know. We need biomarkers to identify patients who will derive any benefit from this combination. And in order to identify this kind of biomarker, we launched in France a randomized phase 2 trial called Bionic, and we select patients based on molecular groups defined on frozen tumor samples, and based on these molecular groups, we allocated treatment to double IO nivolumab ipilimumab, or nivolumab alone, or TKI alone. And with this kind of approach, I think we are going to find some biomarkers of response, and the trial is closed, the inclusion of the trial are closed, and so we plan to show the first result, I think, at the end of the year at the ESMO Congress, and we will see if we can try to find the good biomarkers to respond to this treatment, because we have a challenge on toxicity concern, of course, and we need this kind of biomarker-driven trial.
Thank you.